me know. I hope that most people have now joined the meeting. And I wonder, Stephen, if you could report on any apologies for absence. I know of Andrew Grimshaw's, but I haven't been alerted to any others. Is Stephen with us? Barbara, perhaps, do you know?
Yeah, that's correct. It's just Andrew.
Just Andrew. Many thanks, Barbara. I'd like to give a particularly warm welcome to our new group executives, some of whom haven't been in a public ESTH board before, and also to Carol, who is representing Andrew Grimshaw this morning. I think the rest of us are probably all pretty familiar with each other and with the format. So without further ado, moving on to item 1.2, declarations of interest. There's obviously a large number of people who are twin-hatted and need to declare an interest in both in George's, because they have positions in both George's and ESTH. Are there any other declarations? Aruna.
Doing some work for Herefordshire and Worcestershire Trust.
Thank you, Aruna. I know that some people are struggling with IT today, and indeed my own has already let me down in an earlier meeting. So I think if people can't hear me, can they shout? Because sometimes you carry on talking to yourself without being aware of the fact that other people have lost you. Stephen.
Just to flag that Kate Slemick and Richard Jennings are having some technical problems getting into the meeting, so they hopefully will be joining very shortly.
Thank you, Stephen. Right, can we agree the minutes of the last meeting of the Trust Board in public? I'll take silence as assent. There are no there's no action log or matters arising. So we can move on to item 1.5 and the Chief Executive's update. Jacqueline.
Can you hear me, Gillian?
I can.
Oh, good. Thank you. So thank you very much, Gillian. I won't go through the report in full. When we wrote this report, actually, we were seeing declines in COVID, but we're starting to see that uptick being admitted to our hospitals. Still roughly the same proportion in terms of 70% are incidental and 30% are coming in because they need some support with their COVID illness. But that is beginning to put more pressure on our hospitals. And I'm sure that when James goes through our performance report for Epsom and St Helier, he will talk more in regards to that. I was also asked to be at the launching of the Secretary of State's vision and strategy for the NHS this week. And it was good to hear that actually there's quite a lot as a system we already are doing. So, for example, giving patients choice about having their operation somewhere else that has shorter waiting times. But I think most of you have seen the coverage in regards to that, and also that you are aware that as a system and as an organisation, we are doing comparatively well with not just London, but the rest of the country, for which that is a daily battle for our site team to keep on top of both the emergencies and the electives. I just thought I'd just mention a little bit about VCOD. We now are unwinding some of that. We had already began to put in motion, and I'm sure Paul might touch on this in his report, some of the things that we were going to put in contracts about requiring a vaccination in order to be employed for new starters. So there's a lot of unwinding we're doing, and just supporting staff through what for them was quite a difficult time, despite the kindness and care that we wanted and did show to them. I just wanted to mention also Ukraine, because there's both organisations, and particularly Epsom St Helier, are pulling together items of drugs, bandages, etc., which we are having a central depository point for, which is our South West London procurement, because we do have to log everything we send because for technical financial reasons, but that will then all go nationally, and the national team will sort out getting it to Ukraine. We've been asked not to send it directly there or encouraging staff if they want to help to go via known charities that are working in the region. We've also put out messages to both Ukrainian and Russian staff about supporting them through what is a very, very difficult time to see their relatives and friends and family in their countries being but in both countries really it's really hard. And as we now have our new executive team, we are starting to work through and we'll have a session on this later, how actually we operate at both group and at trust level. And we've been engaging with trust level groups, our trust leadership teams, and also our deputies to the corporate teams around what that looks like and how that works. So we will continue with that as we go. And I just wanted then just to talk about sadly some of our teams that are leaving us. Philippa Jones, our Joint Chief Operating Officer, here is sadly leaving us at the end of this month. She's been the Joint Chief Operating Officer with Sue since October 2019, and Sue will take on and has been absolutely part of enabling Epsom St Helier to reach a good CQC rating. And I'd like to thank her particularly for all the time that she has spent here and the work she has done for us. And also our Carol, who sat here with us today, who's also leaving the Trust to join the finance team at London Ambulance Service. Carol started with us in 2015 as the Deputy Director of Finance with Strategy, and she's now the Deputy CFO for Epsom and St Helier. She was absolutely instrumental in securing the funding for the Specialist Emergency Care Hospital, and I think the board would really like to thank her for all that she has done for the organisation, and we know that she will be much missed. And with that, Gillian, I wasn't going to say any more, but I'm very happy to take some questions.
Thank you very much indeed, Jacqueline. And I know the board will endorse your comments about Philippa and Carol. And our thanks to them for all that they've done whilst they've been with us. So, Martin, I can see your hand.
Yes, thanks. Jacqueline, I wonder if you could tell us more about how it's going with infection control. I'm thinking particularly about it must be much more difficult now that the world has changed so much outside the hospital, where you've got visitors and patients, and we've still got some restrictions and controls in place. How are you finding that?
In regards to, I still am seeing mainly people keep with infection prevention and control rules. But there are sometimes members of the public, and I know that when I walk round, and I'm sure that the teams on the ground are the same, having to ask them to mask up. There is a little bit more of people not doing that and feeling it's all right not to. And people usually comply when you ask. I think that and Arlie might want to add a bit more to this. We've also got quite a mixture of IPC rules now, and so we're working through, particularly for the elective pathways, how we might, what do we need to do for what pathway? Because I think there are some pathways where we are going to extraneous efforts for IPC, i.e. 3-day PCR, and patients just don't want to stay at home for 2 weeks and miss work and have a PCR rather than have a lateral flow test on the day. And the odd areas where we might need to have a PCR and people have to stay at home. But generally, I don't know if Arlene, would it be all right, Chair, if Arlene just gave a bit more if she feels able?
Of course. Arlene?
Thank you. Thanks, Jacqueline. Thanks, Gillian. Yeah, I think it is difficult, Martin, as you said, because the rules have changed outside of the hospital setting, or outside of the care settings, but it hasn't for us. And what we've been doing is spending a lot of time reminding staff that it hasn't changed. For staff coming to work, and unpacking the new guidance has been tricky sometimes, but we will continue to do that. And as Jacqueline has highlighted, we are actively looking at how we can improve, improve using the guidance that we have to ensure that we are able to get patients through our hospitals for their for any investigations or procedures that they have within the remit of the new guidance around do we do PCR or lateral flow testing, and we're looking at how we do risk assessments for patients, because not everybody is going to be able to comply or to work in the same way. So there's a lot of work going on around that. We're continuing to work with the Southwest London team as one infection control team, really, and relying as well on the London guidance coming out. And it is changing as rapidly as it changed, quite early on in the pandemic. It's changing rapidly in unraveling it, but we're having to ensure that we do that safely. And so that's the focus.
Thank you, Arlene. Martin, is that okay?
Absolutely, thank you.
Peter.
Thank you, and thank you, Jacqueline, for your positive report on developments in the very challenging times. I just wondered if you could say a little bit about progress on addressing backlogs which may have built up during COVID and those kind of pressures that at the same time as having to manage staff who are, exhausted from COVID and need to take some leave that they haven't been able to leave. So there's a kind of presumably a balancing act that you're trying to manage there, but it would be good to hear just a little bit more about how you see the overall picture in that respect.
Well, I think this month is particularly difficult because we have got a lot of pressure in our system, whether that be Epsom and St Helier or the greater Southwest London system. And we are having diverts from one of our colleagues because of struggling from that organisation on a regular basis, which is adding pressure, which we need to resolve together. This isn't just their problem, it's our problem. If they've got a problem, we've got a problem. But it does mean that we get ambulances batched into our emergency care unit, emergency care department, which isn't helping. And Sue and I talked at ICS level this morning about that, Sue Jones and I, about how we need to try and help that. And then as you say, we're trying then to get our elective programme in, and the staff are completely exhausted, and we do know that we have staff that are burnt out. And this month particularly is difficult, not just because we've got pressures in our emergency care pathway, but also we have encouraged staff to take holiday, and we know that everyone's gone to the max all month to try and get staff, which has actually left us with some staffing issues as well. So we are trying to do both. So we are walking a tightrope. I think it might be more helpful for James Bly to talk in his bit when he talks about performance, about how we're managing the backlog. Otherwise, I might steal some of his thunder. But I would say that we know it is tight. We know we have staff that are tired, and it's unrelenting on the emergency care. Well, it's unrelenting on all the pathways actually, and quite demoralising for them. But we are continuing to walk round, give them as support we can. I think we probably need to have a bit more thought about what more support we can give at the Epsom St Helier site, how we can actually make sure that we've got enough people, particularly counsellors walking around, staff support walking around, just to make sure that we're picking up staff before it gets too late as well. It is tight, and it is a tightrope. It really is a tightrope. But I'll let James describe that a bit later on, if that's all right, Peter.
Yeah, sure. Thank you very much. Yeah.
Thank you, Jacqueline. I can't see any other hands. Jacqueline, can I just check something? In your report about next year and electives, it talks about 110%, but elsewhere the figure used has been 104%. Is that just a typo?
No, it goes to 104 and then eventually rises to 110, Gillian.
Okay, thank you. That's very helpful, because elsewhere in the papers we use the 104 figure, not in your report, but in other papers. So I just wanted to be clear, and given that this is a public meeting, and for the public to be clear about that. Okay, if there are no other points, we're asked to note that report, and that takes us on to item 2 of the agenda, where we go through the committee report. So we're going to start with audit. Peter.
Thank you, Gillian. And the report was quite late because we only met earlier this week, but nonetheless, there was a private part which I can reference in the next part of the meeting. But on the public section, then there were 3 or 4 areas that I just bring out. Firstly, we were given a progress report on the audit for this year, which seems to be going well from both sides of the external audit team as well as the in-house team have been working well. We received an interim draft of the VFM report, which is now a requirement alongside as part of the audit process. And this was actually earlier than we expected, but appears to be in good shape at this stage. There's still some further work to be done, but nonetheless in a good place. And I'm pleased to report there was a couple of examples of good practice that were referenced there by the external auditors around risk and contract management. So it's helpful to have that external validation of where there is good work. And I'd just like to pay credit to the teams that who are leading on all of that. We also received, in relation to the internal audit work, progress on implementation of recommendations, which has been an issue in the past. And I know that it's high up on James Blythe's agenda to work closely with his team to make sure that recommendations from internal audit reports are implemented in a timely way. And I think some good progress, but more to be done. And I'm confident that that will remain a priority on James's agenda. We had 3 reports on medical devices, data quality, and the general ledger, and generally all in a good place, but with some management recommendations on medical device and data quality, which is already been addressed. And then we had brief reports on counter fraud and cyber. Cyber, there's a bit of a challenge about a need to catch up on some of the training. It's below the target level, again, for understandable reasons. But I think it's again important that the cyber training across ESTH is we now pick up and seek to reach the target, because it protects everybody if that training is being completed. And then finally, we also had a discussion around salary overpayments and GP overpayments, which again, we're going to get further reports to the next meeting. So I won't say more about that at the moment, although the issues there are continuing. Thank you, Gillian.
Thank you, Peter. That's very clear. Any questions from colleagues?
No, because I can't get in any of this.
Sorry? Somebody, I think somebody must have their mic on. I could just hear somebody talking. Right, there don't seem to be any questions, Peter. So thank you very much indeed for that. We're asked, the board is asked to note the report if we're happy to do that. Can we move on then to 2.1b and the Estates Assurance Committee? Anne.
Thank you, Chair. So I won't go through all of the detail in the report. As the board will know, this is a new committee set up because we're very conscious that whilst we wait for the new hospital, we're still carrying quite a lot of risk around our existing estate infrastructure. And we needed to make sure that we have proper focus on that. So this was the first meeting, and to a large extent, we spent our time bringing committee members up to speed. So we looked through the terms of reference, checked that we were comfortable with those. We looked at the information around the estate condition and the estate strategy, and we reviewed where the trust was against standards. And I think it was a very useful meeting in terms of kind of laying the groundwork for the future. I think the important thing for us, and this is what we agreed at the meeting, is that over the next few months, we will do some deep dives looking at some of the issues related to the risks that we've been carrying. And our intention is to look this month at water and next month at ventilation, to make sure that as we build the new hospital, as we make progress with that, that the risks that we're carrying on our existing infrastructure are mitigated to the extent that they can be. So I think at this stage, I probably won't say any more. But if there are any questions, obviously I will do my best. What I should say is one of the things that we addressed was the sort of live issues, and there had been some particular issues around Beacon Ward, and I believe that we've now satisfactorily moved from Beacon Ward. And I just wanted to pay tribute to Trevor and his team for some really good work in order to bring that forward, because the board had been a little bit anxious around some of the issues that we were carrying in Beacon Ward. I see lots of hands. I'm hoping that somebody else has also, if they're detailed, that other people have got the answers. I'm not sure if Gillian is struggling. Are you there?
No, it's fine. Thanks, Anne. Annoyingly, messages pop up on the iPad, and you can't get to unmute yourself until you've got rid of the message. You know. Anyway, I do have a list of names actually. James, do you want to go next before I bring in Chris and then Martin?
I was just going to confirm, Chairman, that Beacon Ward moved yesterday.
And I have to say, James, we were, the Neds had a little get together. We were delighted to see that because I know how hard that's been for everybody. And well done to you and the team for making sure that the timetable for what was a big and complex move actually happened to the benefit of our patients and staff. But none of us underestimate what was involved in that. So a big well done and thank you. So Chris and then Martin.
Thank you. I think I know the answer, but just want to check that obviously St Helier Hospital site and Epsom Hospital site are by far and away our biggest estate's responsibility, but the committee is dealing with the entire Epsom St Helier estate, including the community hospitals and renal units. Is that correct?
That's certainly my understanding, and I think I saw James nodding, so I'm hoping that is the case.
Good. Yeah, I think so. Thanks, Chris, for that. I think it is an important clarification. Martin.
Yes, and I'm just wondering how much external assurance we get and how much is planned. So my thinking is that we know that we've got a very old estate which has significant risks. We've got an internal estates team who do a great job. And I know that we have various external people doing different bits and pieces. I'm not sure if this is part of it, but for instance, I saw something in the report about authorising engineers. Wasn't quite sure what exactly that was, but I'm thinking how much of the assurance work will be done by you receiving independent professional assessment of risks.
So we do indeed have authorising engineers report, which I got quite familiar with in kind of some of my other trusts. So they will look at, these are independent people who come in and check against national standards for things like water, electricity, and all ventilation, those sorts of things. So we do have people who will come in and give us external views on that. I believe where we've got particular issues, so like with the Beacon Ward, we did have external people monitoring some of the issues around that, so that it wasn't our own people sort of marking their own homework. So I think outside of the standard authorising engineers reports, we do bring in experts where we think that is necessary. Does that help? I see James has got his hand up. He may be able to give you a more informed view.
I thought it was a rather good answer, Anne, but I was going to ask James if he wanted to add anything. James.
Only that what we've done with the scheduling of the committee, Martin, is that we've looked to schedule the deep dives that we're doing on each area so that they are done with the benefit of the authorising engineers report for that area, so that we can basically look at the external assurance and ensure that that is fully incorporated into the work of the committee.
That's great. Thank you.
Thank you, Martin. I can't see any other hands, so could we note the report? I'm glad to see, Anne, that it's got off to a good start, and the focus on water and ventilation, which I think are the right things. So that moves us on to 2.1c and the people committee, EDIS. Since the floor is, I want to go to the people focus, and then we can take questions of you.
Okay, fine. So I might have missed a few words there, but I'm going to do both committees together. So first of all, on the EDI, or Equality, Diversity and Inclusion, just a quick reminder for those who aren't familiar with it in terms of the strategy, because this will help to explain why we're doing the activities we are and how they fit into that. So it's a very simple strategy. The first is to ensure that we meet all the compliance requirements. And the compliance requirements tend to come either from legal requirements or from NHS specific regulatory requirements. The second part of the strategy was to ensure that we really promote and celebrate difference and the value of difference. And a lot of the work which is done within the networks is really about that. And then you can't really do this in isolation from questions about the culture and the way that people behave, and calling out behaviour which isn't acceptable, and promoting and recognising the kind of behaviours that we want. So that's the third element. You'll see from the report, a lot of work has been done on the compliance. Two particular areas. First is general legislation for public authorities, which is public sector equality duty, and then the EDS, which is an NHS regulatory requirement, which both of which have had an enormous amount of work done over the last few months. In terms of the networks, I'd highlight the disability one, and I think this is a good example of the value of the networks. We have a problem, and it's a problem shared by most organisations to some extent, that if you look at the answer to the question in the staff survey, where it is anonymous, about 18% of the employees will say that they have a disability. If you go through the process of actually registering that on the HR system so that we can produce data on how many staff we have with disabilities, it's 3.5%. And clearly we need to understand why that is such a big difference. Although, as I say, there tends to always be a difference between those two. And there's a lot of work that's been done through the network and with the support of the executive team to try to encourage more people who have a disability to include it, so that we can provide support if necessary, or at the very least we're able to report data accurately. In terms of the LGBTQ network, of which I'm also the sponsor, a very good session organised with the Surrey Police on hate crime, and particularly hate crime which is relevant to LGBTQ. And Surrey Police have a specialist unit for this, and I'm very pleased to be there and to introduce it. The REACH network, which in many organisations would be called the BME, as well as many celebratory events, they've also done some really helpful work in terms of the EDS and the RES. So it is very much a support and reference group for people who have obviously got lived experience, which is relevant for a lot of the work we're doing. Now, this committee also covers patient EDI issues, and a huge amount of activity in that area, but a few to highlight, some which are less frequently spoken about. For instance, the work on veterans, the work on carers, which is an important issue for both patients and staff who are carers, and also for our very vital volunteers and making sure that we have more diversity in the volunteers. In terms of the broader people agenda, actually in terms of committee meetings, we've had relatively little, because we had an abbreviated meeting during the time of COVID, where we were trying to make sure that we were supporting everybody on the front line. And that was completely dominated by VCOD, which Jacqueline has already mentioned, because the decision was taken really at the last minute nationally to not implement this. Clearly the work, particularly by HR and the exec team, all of that work had to be done because it would have been a very, very major change. And then the other area that we particularly looked at was the freedom to speak up, which of course is really an essential area. This is where the Freedom to Speak Up Guardian talks to the committee and makes them aware of issues that that have been raised to them. They're raised on an anonymous basis, but it's extremely valuable that they get exposed at that level of executive and non-executive scrutiny. So I'll leave it there. Happy to take any questions.
Thank you, Martin. Any questions from colleagues? Aruna.
Not a question really. Also to share, Martin, the Women's Network. We celebrated International Women's Day. I'll let James speak to it. He was our keynote speaker.
Did you want to say something, James?
Only that I was extremely flattered and probably a little bit daunted to be asked to be the keynote speaker for the International Women's Day event. And I thought it was, it was a really well targeted, really well focused event. And I certainly took a lot. I wasn't able to stay for all of it, unfortunately, but I took a lot from the other speakers. We had a really good conversation about allyship in particular, which I think was really helpful. I think my reflection, it will be part of my weekly message today. I think my reflection coming out from it is possibly how we need to try and widen the discussion, because the allyship discussion is one that needs to be had much more widely than we were able to have on the day. But it was I agree with Aruna, it was a very good event.
Thank you, James. I can't see any other hands, but Martin, I had a question that arose from your report, but it may be a question to the executive rather than you. And that is about the formal reports arising from the public sector duty and the specific NHS requirements. Do we have a timescale for the completion of those reports? That's why I think it's probably for the executive, but please. Well,
yeah, it is, in the sense that I know that the work has been done, but obviously it needs to go to the exec first for approval, before then it comes to the committee or to me as chair, and then published. So I see Jacqueline has got a hand up, so she can update on where exactly they are in that process now. And Paul.
Paul might be able to update on it when he does a bit report, but my understanding, it doesn't have to be on there until the end of this month.
Yeah, that's right.
And we're trying to get both reports to look relatively similar and to the point and clear. But that is my understanding, and that is what we are working towards and on, Chairman and Martin.
Well, that's good enough for me. I just felt it was important that Martin had made the point about our specific duties, that the board needed assurance that we would meet those requirements. So, short of time, open up a big discussion, but I'm sure we can note that in it. And unless, Paul, you particularly wanted to say anything, I don't require you to. If you wanted to, I wouldn't.
No, I think Jacqueline said everything. We're just trying to make sure we coordinate our approach. But I think this month is what we're going to be focusing upon.
Okay, excellent. Many thanks. If there are no other questions, could we and move or both?
We missed a lot of that, Gillian. Your the connection was a bit dodgy.
Okay, I think I got the message. She wants Derek and me to proceed, so I'm happy to do that. So Derek and I jointly chair the Patient Safety Quality Committee. And Derek, please chip in and put your hand up if I haven't covered sufficiently. So we've had 2 meetings actually of PSQ, one in January and one in February. We've covered quite a lot of things, already. So I will really touch on the things that haven't been covered so far in the meeting. So I think the first one really to talk about is the patients who failed to attend radiology diagnostic tests. So we were informed in January that we had a situation where there were patients that did not attend radiology tests, and because they hadn't attended, we had followed up with them, and what came to pass was there were in excess of 8,000 such records where we have not followed the when they did not attend. So obviously from a PSQ standpoint, there is concern and about from patient, have we harmed any patients? So we are currently in the process of going through and reviewing all those records. We're a quarter of the way through, and so far it appears that some of them may have been seen, but indeed we haven't recorded it. So it's kind of more a recording problem than a patient harm problem. If, of course, we find any patient harm, we will be treating those as SIs. So more to come in this space. We'll be following it through PSQ. It is a large task, as you can see, 8,000 plus patients, but we are making headway on that. I won't touch on the COVID recovery and operational challenges because I think it has been touched on. And ditto with IPC. I will share a little bit about fundamentals of care and the work that we are progressing on in terms of ward accreditation, really looking at tissue viability, falls, etc. The work has started. We have covered 14 wards, bronze rated them, so that is again work in progress, and actually an excellent initiative in terms of improving the quality of care. I think this is an important point. We have changed or upgraded, really, I would say, the quality priorities for next year. And what is, I think what the thrust is going to be is 3 large categories, which are related to patient safety, clinical effectiveness, and patient experience. And then underpinning those, really, the priorities that will support us to deliver to those large objectives. So we went through that at PSQ, and I think we've also made the effort to line it up really from a group perspective, so they are synchronized really with the St. George's priorities. We were required really, or we are required really, to have national surveys. We had the results of 2. Both of which actually, I won't go into too much detail here. You can see the detail here, one related to inpatients and the other related to children and young people. I think we did relatively well. Of course, the response rate in this climate has been lower than we would have liked, but based on what we had, actually, we came out quite well from an Epsom and Helier perspective. I think there is a paper on emergency preparedness and resilience, but this was also something we discussed at PSQ. This is really what I would call, our business continuity plan. If there was an emergency, how would the trust cope? We were walked through that, and there's substantial assurance really on that. And then, of course, there were the regular reports to the committee, and the regular discussion in terms of quality priorities, SIs, and the corporate risk register, and maternity. Again, I won't talk about that because we have a paper, a separate paper on maternity. I think that was all I was going to cover. Derek, is there anything you would like to add?
No, thanks, Runa. I think that's been really comprehensive. I would just flag out a couple of things. One of the things I was very impressed by was the amount of work on flow, particularly flow through ED, that the operational team have been doing to try and keep people moving through the department and getting to the right care, and different types of care that people need when they walk into the ED, and getting best care for people with dementia. And we had quite a discussion at the last meeting about how we optimize training for staff so that we provide best care to patients with dementia, because I think this is a group that we really need to step up to the mark to make sure they get best care. And I suppose the other thing that was on my mind was there's a triangle of medicines management, antibiotic stewardship, and C. diff cases that we talk about and have been trying to optimize. And I guess I can't remember if you mentioned it. The other thing that's been taxing us a bit is mental health in young people, which is they sort of, well, a lot of what we do is within the context of acute trust, and it's not always the best place for young people with mental health issues, and trying to optimize their care, I think, has been something we've talked about quite a lot. So just flag up those issues. But a lot, I mean, I guess what you've captured is a lot of stuff comes through PSQ, and it's been a lot of work. So thank you, Aruna.
No,
Thank you, Derek. Thank you, Aruna. Let's move on, because if there's questions, we're short of time. So any questions to Derek or Aruna about the quality committee paper? So if I've got a couple of questions, actually, if there are none from others. You referred, Aruna, to the work about the radiology, and but I'm interested in the timescale for completing the review work. You said you were a quarter of the way through. So when will we have done 100%? It may not be for you, it may be for an executive, but I'd like to know the answer to that. Does anybody know?
I think, in fairness, I think Gillian Sue has a handle on it, and she isn't here. So could we bring that back to board?
I think there's just a
yes, tracking.
It's just an action point to make sure that we have an end date and that we can, so that we can be assured that we're working towards that. And my other point, again, Aruna and Derek, it may be more for Arlene. Are we satisfied that the aligning our quality report with George's is the right thing to do? I can see that it's the convenient thing to do, but is it the right thing to do? And if it is the right thing to do, it looks a bit different at the moment to the George's one, and it may be that that's because we're aligning it as far as is appropriate and no more. So I'd just like some assurance around that. I think that may be for you, Arlene, is it?
Yeah, thank you, Gillian. I think the first thing to say is that work on these priorities had begun in George's and Epsom and St Helier prior to the group coming together. But when we looked at what was in those proposed priorities, they had already aligned themselves anyway. And so this, for us, it was just about how we smooth that over. But actually, the things that we need to focus on, priority, sepsis and some of the others, had already been were already included in priorities for the separate organizations, and them coming together as a group is the right thing to do. But what we have done is we've ensured that there will be a couple of things that are specific to the organization, and they still have that as their priority, which is separate, but will still be reported together.
Thank you, Arlene. Chris?
Thank you. There's a question in the chat room from one of the attendees, which I think is pertinent to this, to these issues, which is it okay, and I would support the question, is it okay if I ask the question? It's regarding DNAs and GP notification.
Yes, that's a fair point, I think, Chris. I believe we did have that dialogue actually at PSQ about whether the GPs are notified, and I believe they are. But obviously, in this particular instance where we found no response, I'm not sure that that necessarily happened in all.
Okay, well, James has indicated, so let's see if he can cast any light on this.
Yes, policy is that everyone is that's a GP letter of notification will go out when a patient DNAs, and this is done in order to ensure that if the patient does need to be clinically seen but has been discharged, then the GP knows and is able to discuss with the patient and refer in. So I can confirm that that is our policy.
Thank you very much indeed, James. I can't see any other hands, so could we note the quality report, please, and move on to the Finance and Performance Committee. Anne.
Thank you, Chair. So at this time of year, the Finance Committee is very much focused on sort of 2 years, the in-year position and what's going to happen for next year. I'm always amazed at how late the NHS does its planning, and that's not a fault of the finance team here. It's a fault of actually being given allocations really late. Indeed, Carol and I were exchanging emails earlier today about some notifications within the last couple of days. But so we have been doing quite a lot of work on what the plan for next year looks like, including having a special meeting earlier this week. But we will be taking those discussions for now in the next part of our board. In terms of where we are for this year, very much on plan. I think we're expecting to end the year pretty much where we've been saying we will for some time. And that includes delivering on cost improvement programs, which is always difficult when the workforce is flat out delivering care and is very tired and sort of run down, but they have delivered on cost improvement programs. The challenge will be, and this will impact on next year, that quite a high proportion of those are non-recurrent. So it means starting next year with an even bigger gap. But nevertheless, in terms of in-year position, I think we're in a good place. We always look at the capital programme. I'm always slightly anxious because when we look at how much we've spent year to date, we're always a bit behind, and we forecast that we will deliver on the capital plan. But I think we took good reassurance from both estates and IT that we have plans ready to make sure that we do deliver on the capital programme. And I think indeed that's the history of the trust, that we box and cox a little bit and make sure, given our need for capital, that we actually that we do that. So again, I think we're in a good place there. On operational performance, some of this has come up already, but just a few points. There's been quite a lot of sort of talk in the media about patients waiting over 104 weeks. And I think we're now in a very good position where we've got no patients waiting for more than 78. That itself obviously is not a great place to be because we want people to be treated much more quickly. But I think we've made, as a trust, really good progress on bringing down the really long waiters. Aruna mentioned the diagnostic tests, and although there's obviously work to do there, it is improving. And I think we should commend that. I think the kind of focus of the conversation really was twofold. One is that the demand for care is enormous and rising, and that's obviously putting a lot of pressure on the organisation. Some of that will be people who've not come forward during COVID, but obviously a huge increase in demand. And we're looking into, particularly in Merton, we're looking into why that might be the case. But then also what happens, and I think Derek mentioned flow through the hospital. One of the challenges that the hospital has to work as an integrated whole. And one of the challenges that we were talking about at the Finance Committee was the ability to discharge people. So we're probably discharging half as many as we would normally. Well, if you can't discharge, you don't free up beds that allow you to pull people through from accident and emergency. So I think we recognise that we didn't identify anything that the executive could do that they weren't already doing, but I think we recognise the pressure that people were under, and the work that they were doing to try and make the system move even better. Finally, I think as a trust, we've said this a few times, there's more work to do on risk, to sort of, I think probably to streamline the risk register, because it's a little bit unwieldy when we look at it, but we do look at it. And actually at our last meeting, we reflected changes to 2 risks, one around the Building Your Future Hospital, reflecting the current sort of timelines for that. And then we downgraded a risk around sterile services, where we were assured that actually that didn't now need to be on the risk register. So I think that was all I wanted to say, Chair.
Thank you, Anne. That was really comprehensive. Any questions to Anne? No, can't see any hands. So if we could note that report, please. So that takes us to Sutton Health and Care and Surrey Downs Health and Care. Chris.
Thank you. Thank you very much. This report largely has amalgamated the issues around the community services for both Surrey Downs Health and Care and Sutton Health and Care, because so many of the issues are entirely similar, rather than that they are the same 2 organisations. The governance and assurance meetings take place for both Surrey Downs and Sutton Health and Care on a monthly basis. And on top of that, some developmental sessions have also taken place. Both Surrey Downs and Sutton are at the forefront of integration work across social and healthcare and primary care services, and are very keen that we stay at the forefront of those developments. One of the key things I wanted to pick out of the report is the urgent community response service that will be a nationally mandated and monitored service from next month onwards, and we've been running that in shadow over the last few months. And the target behind that is that any urgent referral will be assessed within 2 hours of the referral being made. And really the structure that's been built has built upon all the work that was done during COVID, when it was absolutely critical to tie up community hospital and social care services to look after patients in the safest place. As with everybody, operational pressures stay high, and referral rates to the planned, both the urgent care and the planned care services of the community services have now reached pre-COVID levels. Waiting lists are being actively managed and have in most areas started to come down. One of the things we have noticed is an increase in the DNA, did not attend rate. And in Surrey Downs, they're putting in place a text messaging service to remind patients just beforehand of their appointment. Though I know some clinicians do feel DNAs help them manage overbooked clinics. You know, what you lose, you gain a few extra bookings and you lose a few people who don't turn up. So one needs to be mindful of the pressure that a 0 DNAs would probably put on clinicians. The business planning has taken place and looking at the finances for this year and next year. And in community services, finances for this year are looking healthy and meeting targets. The other thing I just wanted to pick out was relating to Sutton Health and Care. First of all, the community services there received a 96% positive friends and family test, which is much to be congratulated to them on. And also in Sutton, one of the priorities that we're building on, but again comes out of the work that developed during COVID, is joint working across health and social care to support people with learning disability in the community, both in their own homes and in care homes. That's what I have to report. Happy to take any comments or questions.
Thank you, Chris. That's great. Can I add my congratulations? And I'm sure the whole board, 96% is a fantastic result, isn't it? Any questions or comments to Chris? I can't see any hands, so we will note that report. I'm conscious we're quite tight on time, actually. And before we leave this section of the agenda, it struck me that if we have formal reports on equalities issues that have to be published by the end of the month, there needs to be some formal sign-off process by board. So I wonder if the board would be prepared to delegate that to PCE committee, which has a meeting on the 28th of March, I think. Board happy to do that? Martin, I hope that's okay by you.
Yes, that's what I was hoping would happen. Yeah.
Yeah, I think we just need to formally delegate it on the part of the board. In an ideal world, we would have wanted it to come to board. Right, thank you, colleagues. Right, I'm going to rattle on now to item 2.2, the integrated performance report. And James, you're going to highlight anything for us, and then I will ask if any other exec wants to add anything, but over to you, James.
I mean, to be honest, Gillian, I think a lot's been covered in the committee reports because the IPR has already been to a number of committees, so I won't go over old ground again. I think just probably a couple of things to highlight. The first is just to note that we had a particularly high month for turnover in January, so I think that we don't understand yet whether the potential move towards VCOD was having an impact on that. So we'll be looking to understand themes from information we collect about why people are leaving, and also see whether that carries on into February. It would be, I think, something that we would need to understand in more detail if it continued. I think just one very positive area to highlight is probably our performance around cancer services. So we continue to maintain really strong access in relation to cancer services. So our 2-week wait, our 31-day, our 62-day, and the new faster diagnosis standard as well, where we've been performing consistently well now for a number of months. So I think that's extremely positive. I think probably one other thing that is encouraging is that we've been noting the increase in the planned care waiting list for a number of months, so a very high rate of referral, particularly from some areas of our community. While that went up again in the last month, it did actually start to plateau. We have initiated some work with GPs, particularly in Sutton, to understand the particularly high volume pathways, understand the patterns of variation from practice to practice, so that we can make sure that we are getting the right people into the waiting list. And that we're able to manage that access appropriately. You'll note that the admitted performance decreased from 60% to 50%, but actually what you can see within that is that the number of patients being treated within 0 to 18 weeks continued at the same rate, and we were simply treating more of the backlog. So again, this plays to what we're doing in terms of treating the backlog, and the board will be aware that we have in-sourced staff supporting us with additional capacity in theatres, and we're also continuing to work with independent sector partners as well. So a large part of our planning process is how we continue that into next year in the context of new incentives and targets around the 104%, and also in the context of a new funding settlement as well. I think a lot has been said about urgent care. The hospitals remain exceptionally busy, and I think that comes through the data. We saw a really busy month in January, and then some exceptional patterns of particularly presentation for emergency surgery in February, which means that the situation continues to be very pressured. And I think that we've talked already about all the things that we're doing to maintain flow through the hospital, and indeed work with partners to maintain flow out of the hospital where that's appropriate as well. I think a general trend remains that as we put in place new mechanisms that mean that we support people to go home on the same day or to leave hospital earlier, it means that the complexity of the people who are in our beds and their ongoing care needs is very significant. So that work with partners to support people to move on is incredibly important. And the social care market is particularly difficult at the moment. They are also affected by the same workforce and capacity and infection control issues that hospitals are as well. That was all I was going to highlight, Gillian, as I believe other areas have been covered.
Thank you, James. That's great. And I do think the board would want to put on record our continuing admiration and thanks to the whole team for the way that ED and flow through the hospital has been maintained in the most challenging of circumstances. Any questions for us, or indeed any of the executive on any material in the performance report? Can't see it. Oh, Arlene, Richard and Arlene. So, and Paul. Right. Okay. So, Arlene, should we take you ladies first, and then Richard, then Paul?
Thank you, Chair. I just wanted to add, in terms of the IPR, on the quality metrics page, there is the, and Derek spoke about it before, that the focus on dementia, that we are ensuring that we are continuing to focus on dementia. But I also wanted to add that we have recruited into the clinical nurse specialist role for nutrition, and must has been missing from our IPR prior to now, but we are working on ensuring that that is that gets reported on the IPR. It's not that it is not currently risk assessed or anything, it's just that it's not reported, and we're wanting to improve that. The nursing staff have done a tremendous amount of work around reviewing and revamping the nursing documentation to improve recording and reporting of risk assessments and care given to patients. And that's going to be reflected in the IPR going forward. From an infection control perspective in the IPR, I think it's not great news, but it is worth us highlighting that for C. diff infections, the trust, we are at 47 hospital C. diffs against a trajectory of 42, so just over, but that the rate has declined in the sense that we've managed to stop it going up. It was going up even more than that, and there's a lot of work. We now have an antimicrobial consultant working with the team to look at antibiotic prescribing, which was, we think, one of the issues that we had. So that's important as well from the IPR. Just wanted to highlight those two. I think Gillian,
Thank you, Arlene. Helpful.
Thank you. Just on the general issue of learning from patient safety incidents, it's already become very clear just over a month in that the group offers opportunities for sharing learning. And during February, the two site medical directors have been in close touch around patient safety incidents, and we've had a few instances where we've picked up themes that one organization has thought more about than another. So at the moment, the level at which learning is being shared is really at executive level and in corporate safety functions. But we're looking forward to a time fairly soon, I think, where we'll start to look at ways that we can share that learning with all the staff in both organizations. And there are also opportunities to make some of our functions a bit more resilient through mutual support. And ESTH has had a few challenges in getting serious incident investigations completed because of capacity issues with senior clinicians, and we think we can probably do some shared work to help with that. So just to recognise that there are opportunities, and we're beginning to actually identify what those are.
That's great to hear. Thank you very much indeed, Richard. Paul, and then Peter.
Yes, just two things. One, just to add to James's point about turnover. I don't think ESTH are unusual in that. We're seeing quite an increase in turnover across the NHS Georges, and not being different. I suppose it's that time of year, we're not quite certain whether this is a seasonal element, which you see going up, or whether this is more the trend. I suspect after 2 years of people being fairly stable, this is possibly the start of the trend, which, whilst not good, also means that it creates opportunities for us to see how we might recruit. And then the only other observation I'd make is, I think we need, it's good to see appraisals improving in terms of compliance, but we still need to do quite a bit more work around that area, and really to understand what we can do. Certainly understand the pressure people have been under in terms of completing appraisals with everything else they've had to be doing. But it's an area of focus that I think we really need to consider what do we need to do to improve that, because it is really important.
Thank you, Paul. Peter.
Thanks, Gillian. Two questions. One is, at what point are we towards the end of what would normally be regarded as winter pressures? I don't quite know what this seasonal point, whether we move into spring, but the question behind that is, might we expect some easing off of some of the traditional pressures around at this time of year? Will that help manage the overall position? But the second point is just coming back to the kind of health inequalities issue, if I may. And there was some national data this week on the COVID around the huge inequalities across by gender, ethnicity, age, deprivation, and thinking about how some of that is captured in this report. We see some references as a couple of charts in relation to ethnicity, and by age, but I'm not really sure what they're telling us, whether that's in line with what we might expect, or it's a work to do to impact on the data which is provided. I appreciate this report is going to be reviewed, it's work in progress, but it's just I suppose a push or a request for some analysis to explain to us what's going on in relation to what's here, but also perhaps to extend it into a kind of wider review of where we stand on inequalities. And I know from previously work is going on at a wider level, but to bring it back into this report would be really helpful. Thank you.
Thank you. Could you take, James Blythe, could you take the first one, and maybe James Marsh, could you take the second question? Would that be okay? James, sorry, James Blythe first, then James Marsh.
So I would be hesitant to say that we'll see an immediate drop off. I mean, the tipping point Easter tends to be very busy because we tend to have a degree of staff absence, and we tend to continue to see quite a lot of activity through Easter. We might then hopefully just begin to see a little bit of a drop off, but there have certainly been recent years in the NHS, even pre-COVID, where it's felt like winter's pretty much gone on until about July. So I'm hesitant to say that we'll see some very marked change in the profile of attendance when the weather warms up. That there are some things that are very seasonal. Equally, there are other things that carry on all year. But I think we'll know a little bit better when we come out of Easter, Peter.
Thanks, Peter. I'll pick up the second point about some of the additional data that might be potentially available on the IPR. You're right that we are in the process of reviewing and updating the IPR across Epsom, St Helier and St George's so that we can have a more standardized approach and allow some better benchmarking. It's also an opportunity to include some additional data, such as some of the protected characteristics and deprivation. What we do need to do is to work closely with the executives and the non-executives who lead the subcommittees to make sure that we produce an IPR that is detailed enough, but is digestible as well, but allows opportunity for deeper dives. Arlene and myself have been working closely with Richard Jennings, who's leading on population health management, so that when specific issues arise, it does provide a really powerful tool to do deep dives into certain aspects of care across our communities, and that we can identify if we're observing variance against the expected for that population. So we look forward to getting a richer data set moving forward.
Thank you very much to both the Jameses. So if we could note that report and move on to item 2.3. We're running a little late, so I'd be grateful if we could be as brief as possible. Arlene.
Thank you, Chair. So this item really provides the board with an update on the management of nosocomial infections across Epsom and St Helier. The board, we have brought before a paper outlining how we manage nosocomial infections and the extent to which we have been working to identify any learning from nosocomial infections. For clarity, nosocomial infections are defined as COVID infections identified in patients which were not really, wasn't there on admission, but was identified between day 8 and 14. It's considered hospital onset, and probably hospital acquired. But beyond that, 15 days after admission, to have that first positive COVID test, it's considered definitely hospital acquired. And we have worked all during the pandemic to ensure that we have a process for reviewing those cases, and particularly where those cases result, the patient dies, and sometimes the patient dies because of COVID, but a lot of times they die with COVID, and we review those cases. The paper outlines how we do that, including the rapid response by the weekly panel, how the deaths are reviewed and considered for declaration as an SI. And if it is on part 1 of the death certificate and it's definitely, considered to be the cause of the patient's death, then it's reported as an SI, investigated, and all of the processes that follow SIs are adhered to. The patients who have got COVID, hospital-acquired COVID as well, we ensure that they have structured judgment reviews if there's any concerns, to identify any concerns in the care that they received. And our medical examiner team are heavily involved and ensure that we contact patients to identify any concerns that they may have. We also, as part of the requirement, worked with our colleagues across Southwest London to ensure that any patients who died of nosocomial infections in waves 1 and 2 were notified, their relatives were notified, and we sent those letters out, and we invited the relatives or the next of kin to contact us if they had any concerns. We have sent out now over 90 letters, and we have only got four sets of relatives wanting to speak with us. I mean, it has highlighted some issues as well in terms of the fact that we did not have any contact details for next of kin for at least 2 patients. So we're also working through those. So the paper is really just about summarizing all of that and assuring the board that we have really a really robust process for reviewing the deaths of patients who die of nosocomial infections, but nosocomial infections in general. And I'm happy to take any questions.
Thank you, Arlene. I've seen a hand.
Yeah, thank you, Arlene. Thank you very much. I wonder if you could just clarify for the board and the public the difference between a part 1 and part 2 death certificate where COVID is, or any other disease for that matter, is mentioned.
That's probably better done by one of Richard or
very happy
James. So yes, Richard's hand has gone up.
I think it's a Richard issue. Richard, could you explain?
I'll try and remember the exact wording, but part 1 is a list of those conditions or that condition which directly caused the death of the patient. Part 2 is a list of conditions which contributed to but did not directly cause the death of the patient.
Thank you very much.
Thank you. Any other questions for Arlene or comments on this? No, so we're asked to note the report. And I think, Arlene, it does give us substantial assurance, actually. So if we can move on then to item 2 for the statement of purpose. Change of registered manager. Arlene, that's you again.
Yes, it is me. Thank you, Chair. Again, the organisation is required to ensure that we have a registration with the Care Quality Commission regarding the activities that we undertake in the organisation for care. And annually, we're required to confirm who the registered manager is. With the advent of the group, we have has required that we change the registered manager for Epsom and St. Helier and for St. George's actually. And this paper here, it really just outlines the updated document, the updated statement of purpose, and is here for final sign off before it's submitted to the Care Quality Commission, changing the registered manager from the previous manager, which was our Associate Director of Governance for Epsom and St. Helier, to the Group Chief Nursing Officer, myself.
Thank you, Arlene. I've actually turned my incoming video off to try and help with the sound because I've been missing some of it, and I think some of you have been missing me as well. So I can't. The only hand I can see at the moment is Chris's. Chris, did you want to come in on something, or is it an old hand?
Sorry, lazy hand.
So I can't see any other hands. So could the board please note and approve the change of registered manager for the trust? Thank you. So that takes us on to item 2.5, the Emergency Preparedness, Resilience and Response Annual Report, which, as Aruna referred to in her report on the PSQ, did get a very thorough consideration at PSQ. So James, you're just going to cover this one.
Yes, so the board is asked to approve the EPRR report and the validated assessment of being substantially compliant. This is an area that I think the trust has strengthened considerably over the last couple of years, and we have a good EPRR team in place. You can see the very thorough and comprehensive assessment process that the self-assessment has been through, and in fact, at points our self-assessment was judged to be too harsh and was actually upgraded by the external reviewers. So that I think is an indication of the robustness with which we've done the self-assessment. There are two areas of partial compliance that we're working on. The first is just to make sure that we apply all of our EPRR appropriately across all the sites that we operate, not just our two main sites. And the second is just to make sure that we have fully updated business continuity plans across all of our operational areas, and the EPRR team are working on these two areas. But overall, Chair, I think it's a positive position, and ask for the board's support for the report.
Thank you, James. It certainly looked positive to me. Any questions or queries on this? No, so I think we're able to give you the support that that you're seeking, James. So that takes us on to item 2.6 and the Ockenden review of maternity services. Arlene.
Thank you, Gillian. So this is a report on the review. So following the publication of the Ockenden report, which was entitled Emerging Findings and Recommendations of the Review of Maternity Services at Shrewsbury and Telford Hospitals. That report came out in December 2020, and NHS England wrote to all trusts providing maternity services, and we were asked to confirm and commit to implementation of 12 clinical priorities, which were identified from immediate and essential actions detailed in the report. The trust responded on the 18th of December to confirm our commitment to ensuring all the urgent actions identified were prioritized in our trust, and we had to respond to the local maternity systems as well. We were also asked to provide a review of maternity and report to the next public board, and ask the board to reflect on whether the assurance mechanisms within our trust are effective. To support these discussions, NHS England asked us to complete an assurance and assessment tool and to share this with the board and the local maternity delivery systems in February 2021, which we completed and successfully submitted as required. We also had a program of peer reviews undertaken to look in depth at the trust submission, and that peer review happened on the 17th of March 2021. Following this, we were asked to upload evidence of compliance or completion of the actions into a nationally developed portal, and we did that in June 2021. In December 2021, we received the outcome of the trust following this the submission. They looked at the evidence, and in January we were asked, NHS England again asked us to provide evidence and assure ourselves 1 year on that we are confident that mothers and babies are safe in maternity units, and to ensure that this is disclosed within our public board by 31st of March. And so this is why this paper is coming here to the public board today. We were also asked to provide further assurance and recommendations on the Morecambe Bay, a separate benchmarking exercise, and to fulfill a workforce report, which we did present to board in January. And that report demonstrated that the trust is well in line with the birth rate plus recommended ratios for our organization. And what that means is that we have enough midwives in our establishment to meet the number of births that we have in a year across Epsom and St Helier. The current position is that the assessment of the outcome of evidence provided by us, we are fully compliant for 19 of the 41 questions. 21 on 21 of those we are partially compliant, and there's only one that we are considered to be not compliant. That one non-compliant area relates to twice daily consultant ward rounds, and it has been actioned, and a robust method of recording has been implemented. It's not that they weren't happening, it's about we weren't recording them adequately. And the 21 questions where we were partially compliant, those are either all now completed or have final dates set. The regional maternity team has requested progress and board acknowledgement to report it to them by the 15th of April, and we're on track to do that. And we are also waiting on a site visit by the regional team, where they will again check all of the evidence that we have. And there is anticipated release of the Ockendon's second report by the 22nd of March. So this paper is coming, it has come for noting in terms of updating on where we are with the Ockendon review and the Morecambe Bay recommendations.
Thank you very much for that very clear and thorough taking us through the report, Arlene. I wondered, Aruna, whether as our board champion for maternity services, there was anything you wanted to add?
No, I think Arlene articulated it really well. As she said, you know, there are gaps. It's not like we're fully assured, but you know, that is to be expected. But the fact is, we are aware of the gaps and we are doing something about it. So yeah, I think that would be my only thing.
Thank you, Aruna. Any questions from colleagues? No, I can't see any hands. I think we're asked to do a little bit more than note the report, aren't we? We're really asked to reflect on the assurance mechanisms. And I think from what Arlene has said and what you have endorsed, Aruna, as the champion, we can take good assurance from all the work that's been done and have confidence in our maternity services. Is that a view that the board would support? I'll take silence as assent because I've had to switch. I can't even see any of you because I've had to switch off my incoming video. Right. So on that basis, we're going to move on to item 3 on the agenda, the governance section, and a report on the executive membership of board committees. Stephen.
Thanks, Gillian. So this paper seeks to clarify the executive membership of board committees following the establishment of the group executive at the start of February. In essence, it sort of says that the group executives are as the accountable board directors are the members of the relevant board committees. This is mainly a tidying up exercise while we go through the process of reviewing the terms of reference in a more deep and fundamental way to consider what we want for the year ahead, reflecting feedback from committees and also in terms of planning for the group model more generally. So this is a tidying up exercise more than anything else, but it's quite important that we do so there's no ambiguity around who are the members of the committees, particularly during the course of March, until we agree the membership going forward on a longer term basis. So as I say, this is a tidying up exercise to ensure clarity about accountability and responsibility rather than a deep review. I wasn't planning to go through the proposed membership for each committee, but broadly speaking, where the membership was the previous ESTH executive team, generally speaking, the intention on this is to transfer that to the group executives.
Thank you, Stephen. I think it's very clear, but there may be questions from colleagues. No, can't see any hands. So we're asked to approve the consequential changes to the membership of board committees following the commencement of the group executive as set out in section 3. Oh, Jacqueline, you wanted to come in?
Yes, I do want to come in, Gillian. And the only reason, main reason I'd like to come in is that we're putting in an awful lot of onus on the chief nurse and chief medical officer, as well as the managing director. And I think the managing director is, I think that's just how it is. But I just wonder whether some of this, for example, the bit about the people committee, sorry, I've got hiccups. Does it really need to be James and Arlene in there as well? Richard and Arlene, and actually, is there not a role in some of these also for James Marsh? Sorry, those of you who are thinking you ducked out of some of this. I'm just wondering whether we can appropriately share this out a little bit more than that.
So,
sorry.
At the moment, at least, all of the ESTH, or generally all of the ESTH board committees include every member of the executive team as a member of the board. So actually this does reduce the pressure in terms of where the responsibility lies, because at the moment everyone has to go and everyone's a member. So that does actually change that. I think it's a good point about whether it requires both the chief nurse and the chief medical officer. And as you'll see from the papers proposed for a subsequent meeting later today, there's actually suggestion that we have clinical representation, but that it is either the chief medical officer or the chief nurse. For the purposes of this, just to clarify in the short term, just felt that it was more straightforward just to go with that. But
forgive me, Stephen, I've no wish to put every member of the executive on these committees. I don't think that's right. But I am just wondering whether instead of the chief nurse or chief medical officer, actually whether the deputy chief exec should be part of some of this, particularly in the finance performance.
Yeah, I understand the point, Jacqueline, but isn't this just for this month, really?
It is. Assuming that we agree.
Yeah.
Yeah, assuming that we agree the board committee plans subsequently, this is just a tidying up exercise for March only.
Yeah, my feeling, Jacqueline, is that we leave this for March, just because it is this tidying up for March. I think your point is well made, but I think that needs picking up for the future, rather than us try and rewrite this now in board. Are you happy to proceed on that basis?
Yes, forgive me. I missed the bit that said it was for March only. My apologies.
Yeah. No, that's absolutely fine. So if there are no other points, I won't read the recommendation again, but emphasise that this is, as Stephen said, very much a tidying up exercise to get us through this month, to make sure that that the accountabilities are absolutely clear, and then there will be the new arrangements for the future. Is that agreed? Thank you, colleagues. So that takes us on to item 3.2 and the non-executive director lead roles. Stephen, you again.
Yeah. So this is a paper which proposes how the trust might respond to the guidance produced by NHS England and NHS Improvement back in December. So they undertook a major piece of work looking about how non-executive director lead roles across the NHS had evolved over the past few years. And they particularly highlighted the proliferation of NED lead roles, so resulting from various requirements in legislation or guidance or emerging from various national reviews, and indeed also local arrangements. And what their proposal is that we need to make sure that in the proliferation of roles, we need to make sure that the NED lead roles are adding value and they're not taking away from the way in which board and board committees do assurance. There were some trusts across the country where the number of NED lead roles have proliferated to in excess of 30 in a single trust. So the suggestion from NHSE&I, and it is guidance as opposed to compulsory requirements, but is that we, generally speaking, seek to take through these issues that have previously been led by non-executive leads and make sure we build that into our standard assurance reporting through the board committees and up to the board, but that we retain 5 specific NED lead roles for maternity, for well-being, for freedom to speak up, for doctor disciplinary and security management. Now, of course, we've got 4 out of those 5 already existing in the trust. So Aruna for maternity and for freedom to speak up, Martin for well-being and doctor disciplinary. So really, it's continuing those, and then we just need to make a decision in relation to security management. And the proposal in the paper is that becomes that is designated to Phil going forward. And I believe that Gillian and Phil have had a discussion about that. All the other previous NED lead roles are proposed for taking through the relevant board committee. Obviously, this is all subject to whatever changes we may choose to make when we review terms of reference for committees going forward. But based on the current terms of reference, that's the proposal there.
Thank you, Stephen. And you're quite right. Phil very kindly agreed to take on what might be one of the most ambiguous job descriptions one has ever read. But there you go. And the view I took, there's, when you get this kind of advice from the NHS, there's just value in just adopting it, and then you're not left in a position of having to explain why you haven't done something, as we have often found ourselves in. So any questions or comments from colleagues, or are they happy to support directions?
Oh dear.
You can all do it. Thank you for that. We will move on now to item 3.3. Stephen.
It was breaking up a little bit, but I think you're asking me to introduce the corporate risk register. So just to give a very quick overview of it, because I think we've touched on the major movements in some of the board committee reports. So just to give a quick overview, so there are currently 35 risks on the corporate risk register, 12 of which are rated at 20, 18 at 16, and 5 at 15. All of the corporate risk register has been through the various or the relevant committees of the board over the past month, slightly longer since the last PCE meeting. So they've been considered by the various board committees. I think Anne has already talked about the changes that the FPC reviewed, so I won't go over those again. And just to say, there was one in relation to the January meeting, the PSQ meeting, in terms of the employment arrangements for community staff, where the decision was made to de-escalate that from the corporate risk register. I wasn't going to go through any further specific aspects of this, other than to note there aren't any changes to the other risks boards here. And part of the reason I'll keep this fairly short is because one of the things that we want to do following the formation of the group model is to undertake a review of the corporate risk register and indeed the arrangements for the BAF to take stock of the approach that we're taking on risk management more generally, see if we can adopt a coordinated approach with St George's to have a consistent approach across the group in terms of how we manage risk, our approach to risk, our policy on risk. And so we are planning to develop this going forward with the relevant leads for each of the risks, and indeed with the committee chairs and a particular role there, of course, for the audit committee. So I wasn't going to say anything further than that, Gillian.
Thank you, Stephen. I've actually switched off my incoming video because my efforts to switch it on just mean that none of you can hear me. So it seems better to do it this way. That's fine. Thanks very much indeed. Any questions? Chris?
Thank you very much. I just wanted to ask about our corporate risk register. Does it feed into any other NHS risk register? And the reason I ask that is that some of our risks are not solvable by ourselves. I'm thinking around some of the mental health issues and so on. So do we influence NHS main risk registers, or does it just get left as is? Thank you.
Thanks, Chris. I think it's a really interesting question to which I don't know the answer. I don't know whether Stephen does. Stephen?
I mean, not in a formal way. So not in the sense that anything on our risk register is escalated up and formally considered at either local system, regional or national. Having said that, mind there are a number of trusts with very similar risks, and in a less structured way, of course, those risks are picked up at national level and at regional level, but there's not a sort of formal escalation route, if you like. And I think some of the risk scores in the corporate risk register should at least be designed to reflect where some of those risks and mitigations are beyond the scope of the trust individually to be able to mitigate those. And sometimes you might therefore see the risks we might be doing all we realistically can in some areas, but the risk score may remain higher, reflecting the level of external risk that we can't fully mitigate, if that helps at all.
It is helpful. I think it's a shame that that are risks that we can't alter. I'm thinking largely around estates and support from other healthcare services such as mental health and so on, that we carry that risk in a way when we can't do much about it. But it is as it is, and thank you for explaining that.
Thank you, Chris. I did think it was a good point. And once at George's, we had a risk that we didn't feel as a board we knew we had to carry on carrying it, but we actually wrote to I think it was London Region, saying that we needed help with this because we couldn't we didn't have the capital that we needed to address an estates issue, I seem to recall. But that did feel like quite an exceptional event, as it were. Thursa.
Yeah, thank you, Chair. I'm less cited on the South West London system, but for Surrey Heartlands, the consolidated risks across all of the provider partners are considered by the ICB through their risk and governance structures. And for Surrey Downs, in the place-based quality and safety committee, all of the risks across all of the providers are actively considered, and a system response to some of those risks is put in place.
Thank you, Thursa. That's really interesting to know. Jacqueline, does it happen at South West London? You wanted to come in.
No, it doesn't happen at South West London, and but I think it is important that we keep an up-to-date and true risk register partly for the very reason you said, Julian, because it was an estates or an IT issue that we had that we did receive extra funding for, and that we wrote that to the national team because we were in financial special measures at the time. Not that regime exists any longer, but actually in terms of us as a board knowing what real risks we have and knowing what we can do, and therefore where we do put things like our capital is really important, as well as how we mitigate that. And I think that's why the risk register and the BAF are so important, that we are aware and we look at them regularly, so we know that what we are doing as mitigations and what we can do with our capital is absolutely upfront with us. So whilst it's not always influencing yet, and I hope Thursday that is where South West London will go, and that might be something that Gillian and I try and take forward with them, that actually it's absolutely important that we have only the high risks that are true and are difficult to mitigate, for us to look at those ones at 16 and above. I don't know if that helps at all, Gillian, but I was going to say what you said, but I just expanded it a bit.
No, that's really helpful. Thank you. And I do think it's something that you and I need to take to South West London. I think it's really interesting, Thursday, what you said about Surrey Heartlands, and we know it was as one of the very early ICSs. It is very mature in some ways, and I'd like to see South West London move in that direction, and I'm sure that the ICS chair will be very receptive to that. So thank you. I've got so caught up in the discussion that I need to find my way to the recommendation to make sure we agree what we need to agree. So we note the changes, review and note the position, and note the Corporate Risk Register and BAF are being reviewed. Are people happy to support those recommendations? Thank you. So that takes us to item 4.1 and the Freedom to Speak Up update. Now, having chivied you all morning to make sure that we didn't overrun, we're actually 4 minutes ahead of where we needed to be. So I don't know whether Moira has yet joined us. Has she? Can somebody?
Yes.
Oh, fantastic, Moira. I'm so grateful. Welcome. I'm sorry I can't see you, because if I put my video on to see you, nobody hears me. So it's more effective to leave it as it is. So a warm welcome, Moira, and we look forward to hearing from you this morning.
Thank you, Gillian. I had joined the board a little bit earlier, so I was aware of you being conscious of time. So I thought that I would just assume that the report has been read and that there are only a few additions that I would like to make to it. And one is that just to notify the board that in January and February last year, we had 21 cases, and in the same period this year, we have had 76. So it is feeling, very, very busy within the service. The only other point that I'd like to make that I don't think I made in the paper was to actually thank staff, thank those who are speaking up, but also on the other side of the table, thank those who are listening up. And we get a lot of great support from, well, to be honest, I think pretty much everybody that we reach out to, but the people that we get, I think, quite noteworthy support from is the HR senior leadership team over here at Epsom and St Helier. So many of the concerns that come to us need HR input in one way or another, and I just wanted to actually say, formally say thank you to, to them. So I think perhaps the most productive thing is if I take any questions on the report, which is very much just a review of the service over the last year.
Thank you, Moira. In fact, we've caught up completely, so you didn't have to rush your way through that. But there may well be questions, and certainly I've got one, but I'll let others go first. Any questions for Moira? No? Well, perhaps I'll ask my question then, Moira. So you referred to the fact that you do get good support from the organisation, and I'm delighted to hear that. But one of the things that I know a number of guardians struggle with is the organisation responding in a timely fashion. So it's not that people aren't willing, but sometimes things are left hanging around for too long, in part because people are busy, obviously. But that really does put a lot of stress often on the person who's spoken up, doesn't it? Could you offer some reflections on that?
I think one of the difficulties of the guardian role is that we actually don't have any teeth, really, in the sense that everything that we do, it's collaborative. We ask people for help, but we don't have teeth. But it's the nature of the role, that we don't. So yes, it can be very frustrating for us as a team when we feel that things aren't progressing as quickly as either we would like or that we feel that the staff member would like. But on the other hand, we are really mindful of the pressures that people are under. I mean, it is crystal clear to us, that people are under tremendous pressures, and that I think that people do the best that they can. I don't think, if I felt it was willful delay, then I think that would be different, but I don't think it's that. I think it is that people are genuinely doing the best that they can.
Thank you, Moira, that's really helpful. And that's encouraged some others to indicate. I'm going to go to Stephen first, because I probably, Stephen, should have asked you as the lead executive whether there was anything you wanted to add after Moira had spoken, and apologies for that. And then I'm going to take Richard, Derek, and then Aruna. But Stephen, you go first.
Thanks, Gillian. I was just going to add to what Moira was saying there about the sort of length of time, and I think it links to another piece which is around education and training of staff, where I think knowledge of freedom to speak up is across the whole sector is growing and developing. And I think there's something about how do we equip our staff to know what to do where concerns are raised, to be able to know how to escalate them, to know who to go to know what the expectations are when they're subject to concerns having been raised about them. And so one of the options that we're exploring is the possibility of bringing in some mandatory training in relation to it. That's an approach that has been adopted at St. George's. It's in its early stages at that trust, but it is a useful tool, one of a number, not a silver bullet by any means. But I think more training for staff at all levels, training for all staff, training for managers, and including training for board members. And I think that's quite key. And I think the other practical element as well is, the proliferation of cases coming up to Moira as Guardian has underscored the importance of us being able to track what's coming in really effectively and have an effective case management solution. And we're just starting looking at what's available in terms of helping with tracking some of that and helping us to be able then to pull some useful, intelligent reporting both up to the board, but also across to teams across the organisation about the concerns that are being raised. So I just wanted to pick up those additional points.
Thank you, Stephen. That's very helpful indeed. Richard.
Yeah, two things. So thank you very much for the report. I mean, the first thing is I think that it's worth reminding ourselves that the Freedom to Speak Up initiative arose, whatever it was, 8 years ago with Robert Francis, really as a way of encouraging NHS staff to speak up about patient safety issues and poor quality care. And in fact, that's not really how the use of it has evolved, and staff tend to use it very much to raise concerns about how they're being treated by each other or by the organisation. And that's obviously a very useful function. It's really, really important. But I think it's important for us to recognise that we have work to do to encourage people to speak up about issues of patient safety that aren't about their own working experiences and circumstances, but about the people we look after. The other point that I wanted to make was that I think we can all recognise, and some of us have had experiences of hearing about incidents where people only have the confidence to speak up about them long after they've happened, when the people who have experienced them have gained the confidence to speak about them through seeing signals or evidence that an organisation will take the issue seriously. And I think it's worth us thinking through very much how we want to signal through our comms to our staff about the kinds of issues that we're willing to listen to and want to hear about and care about. And obviously, ESTH has done that. But I'm thinking in particular that there have been a lot of national reports recently about organisations which now have to introspect a lot on issues of sexism and sexual harassment. And I think it's worth us thinking about the issues that we want to very consciously signal to our employees about, that we care about and we want to support them in raising concerns about.
Thank you, Richard. Really interesting points. Moira, did you want to offer any reflections on that? No requirement to, but in case you did.
No, thank you. I do. Thank you. In terms of what Richard's just said, I think consciously signalling to employees would be very, very welcome, and I think is actually much needed. And I would also like to expand that so that it included very clear messaging about the fact that staff will not suffer detriment for speaking up, because that's again something that we are seeing increasingly, is that staff do feel that they are. So I think that messaging to staff would be really welcome, and I think would also be very timely. In the sense of your comment about that a lot of things that come to Freedom to Speak Up aren't directly what a lot of people would assume our bread and butter to be, it is again absolutely true, and we get that feedback from a lot of people. But I think that the reality is for us is that the National Guardian's Office has said that any concern that a staff member have is appropriate to bring to Freedom to Speak Up. And at the end of the day, if for whatever reasons there are issues for that staff, then ultimately the end result is an impact on patient safety. I have to say it's not as direct, the concerns as we hear in terms of patient safety, as I thought they would be when I started. But I've also found that increasingly as time has passed, we are getting more of those kind of concerns. And I think that part of that is that you have to earn your trust. So whether you earn your trust by dealing with the things that some people, I suppose, if we take the bread and butter analogy, the jam, if we focused a lot on the jam over the last couple of years, I think it allows the bread and butter to come forward, if that makes sense.
It does, Moira, and it's a very nice way of putting it, if I may say so. So, Derek.
Thanks, Maura. And yeah, echo what you said. Stephen has covered this a little bit, but I was, if there's time, Chair, I'd just like to ask Maura to say a little bit more about this comment where you said, we've noticed and appreciate a culture change that we're experiencing, where some senior managers welcome our support and even refer staff to us, as well as raising concerns directly with us. And I thought that was very encouraging. But can you just comment any more on where is that culture change coming from and how do we build on that and develop it? I suppose my question really is around sort of, is that coming from external factors or is it coming from work that's been done internally?
I suppose the absolute truth is I don't really know the answer to that. But my feeling, or perhaps my hope, is that that we've earned our place. And that, obviously, I think that, a lot of these more senior people, I think, who refer people to us now, we have spoken to about other issues in the past. So what I'm hoping is that it's a reflection of that. But the truth is I don't really know why.
But it's good.
It is. Oh, it's definitely good. It is definitely good.
Thank you.
Thank you, Derek. A good question, actually, and a very honest answer from you, Moira. So, Aruna, you are the board freedom to speak up champion, as per the earlier report. So, over to you.
Yes. So, I guess I want to start with firstly acknowledging the work Moira and her team do. I mean, this function, I'm going to call it function for want of a better word, I think has really matured over time, and I think it's the perseverance and the tenacity that Moira shows, and her team really and the passion they have in making sure that they create a better workplace for our colleagues is second to none, really. I just also wanted to put some context, and I'm probably stating the obvious here. As it is alarming to see the caseload kind of grow exponentially in the way that it has in the last year. But I think I just wanted to put a little bit of context on that. So if you were to look at the categories that the concerns are coming from, there is a large slew really where, I will read this verbatim from Moira's report here, where staff hear from staff that they feel wrung out to dry. This is both from clinical and non-clinical staff. Discussions on the ward this week show staff feel that they're continually firefighting and not able to get the cause of the flames. There is a feeling amongst many that there is overload, right? So I think there is a context here. I think there is a context in what we've been through in the last 2 years. So I just wanted to, I'm probably stating the obvious, the exponential rise is not something unexpected. But thank you, Moira, for your perseverance.
Thank you, Aruna. I've got Peter and Jacqueline now. So Peter next.
Thank you. I suppose it's just wondering though whether the fact that staff are choosing to go down this route, possibly in an inappropriate way, insofar as it seems to me a lot of these are really line management issues that should be being addressed with the support of HR colleagues. And the risk if people see this as shortcuts, then it just clogs up the system, and those who genuinely have issues in this space perhaps don't get the immediacy of response. So I suppose in a way it's asking a question almost back to Paul de Gamma about whether there is more that HR could do to, as it were, reinforce the appropriate areas in which these should be dealt with through the line management processes. And if that's not working, this shouldn't be the fallback. It should be about addressing those underlying issues. Thank you.
I think you're right about the underlying issues, but let's hear from Moira, Peter, because I think people don't go to Moira without having tried to sort it out, or they're frightened of a point of approaching other people and things of that nature. So, Moira, your reaction to Peter's points.
One of the first questions that we ask people is who have they raised it with, and the answer that we're trying to get from them and point them to is, have you spoken to your line manager about these issues? And I think invariably, absolutely invariably, people have. So whether it's about capacity of the line managers, whether it, whatever it is, or whether it's that things that just feel a bit difficult, or people don't, often we hear from line managers that they don't feel that they have the training to deal with some things. So I think that we do push back where we can, and we do try to get people to go to their line managers where they can. And recently HR have added in a helpline, which again is where there are easy little answers where if you were to thinking that people were using this as a shortcut, we can refer them to a HR helpline. But my honest opinion is that people are not using us as a shortcut. That's not why they're coming.
That's certainly the impression. I would agree with that, Moira. So I've now got Martin, and then I'd like, oh, and Paul and Jacqueline. I'm trying to draw it to a close. So Martin first, and then perhaps Paul, and then give the last word to Jacqueline before our final word from Moira. So Martin.
Well, at least I'll be very quick. On the point about the growth in numbers, of course, this is also part, I'm sure Areela's absolutely right about what we've been through in the last couple of years, but also with anything like this, it is about the people's increased awareness and the success of the service itself. You know, an analogy would be that across all organisations, there's a huge growth in terms of employees who have mental health problems, and some of that is undoubtedly more mental health problems, but some of it will also be issues that were always there, but people didn't feel so comfortable to speak out and make people aware of the issues. Thank you.
Thank you, Martin. Paul, and then Jacqueline, and then Moira, final word to you.
Just to be quick, I was just going to say, I think one of the real benefits of Freedom to Speak Up is it offers people a solution often, but without the formality. And so to Peter's point, I think if I look at, and I'm not close, obviously, to Epsom and Helia's approach to Freedom to Speak Up, but certainly one of the things that I've seen at George's is that they've been quite successful often in resolving issues informally. And I think that's often what people want. And so you'll often hear people say to you, I want this dealt with, but I don't want to complain about it. And that's a little bit of cake and eat it. But sometimes Freedom to Speak cannot offer a bit of that. But I think for me, the key point, and I'm really pleased, Moira, to hear that you're working well with HR, and I think that's fundamental. I think we complement each other, absolutely, as opposed to overlapping. HR should be there for formalities, but should be there for process. I think where Freedom to Speak Up really helps us is to give us that intelligence, and also, as I say often, try to resolve things more informally and act almost as a little bit of media, which can be really, really beneficial.
Thank you, Paul. Jacqueline?
Thank you very much, Gillian, and thank you, Moira. Well done for bringing the report and for actually everything that I know you do for our staff, who really are the apples of our eye. I think the bit for me is that Freedom to Speak Up is one of the different ways that we can triangulate, as we know, and we have done at Epsom St Helier, triangulate where actually we have some issues. And one of the things that we will continue doing on a monthly basis is triangulating incidents with vacancy rates, with complaints, with the staff survey, with Freedom to Speak Up, because I think then we can look at where we actually do have some hotspots and where we can possibly start to intervene earlier than we are. Because I think once it begins to get into the formality bit, actually you're sort of on a path that might not always be the right one, but it ends up being the only one. And where as well we make sure that any concerns where there are issues between 1 or 2 or 3 members of staff, actually, that we can mediate before actually it really does get to a really difficult place. So I think we're on the right track, and I think we'll do a few lessons learned that were for the quarterly board review of that into a monthly review at execs at site level with a range of metrics that actually will help us a bit more, Gillian. I just wanted to say that because I think I always value the Freedom to Speak Up function. I value what Moira does, and when she highlights issues, I know that she really is concerned because she's heard directly from staff. what's been said, but how we actually begin to bring that into something that might be a bit more preemptive.
Thank you very much, Jacqueline. So Moira, over to you. A final word.
Thank you, really fundamentally, for this opportunity. And in terms of the preemptive work, we've been running a few workshops this last, I can't remember, January and February, which has probably reached out to about 40 people, and it's about working in a team. And they seem to have gone down really well. But other than that, thank you. Thank you for the support that the Trust provides to our service. I think we are one of the best funded services that I know.
Well, that's very nice to hear, Moira. It's very good to hear from you at board, and we need to make sure that that happens regularly. You said at the beginning about lacking teeth, that the function lacks teeth, and I understand exactly what you mean. But I hope that you know that through the support of the champion, the PCE committee, the chief executive, the managing director and the board, you have a lot of support around you to really enable you to do your job well and enable Freedom to Speak Up to be a really valuable resource for staff. So we're asked to note that report, which I know everyone will willingly do. And that takes us on to any other business. I haven't been told of any, and nobody's flagging anything up, which is good. And item 6, the date of the next meeting is 9:30 on Friday, the 6th of May. So we look forward to our next public meeting on that date. And with that, I'd like to thank everyone for attending. Some of us have got another meeting in 15 minutes, so we've got a chance to stretch our legs and perhaps get a cup of coffee. And very many thanks to everybody for their contributions and their attendance this morning. Bye-bye.
Thank you.